it's not. Okay.
Peter, you on?
Yeah. Can you hear me okay?
We
Yes.
can hear you live.
Can you hear me, Chantal?
We can hear you.
Yes, we can hear you, Peter.
Perfect. Thank you. So, good evening, everybody. My name is Peter Duffy. Sincere thanks to everybody who's online already. I'm super excited about tonight's great debate. I'm just going to give a quick few introductions before we get started and before I open the floor to Dr. Federico. So, first of all, my name is Peter Duffy. I'm the Business Development Manager for the Middle East and Africa. I have been with Align Technology since 2013 and have really seen some fantastic improvements throughout the orthodontic industry. And I have to say that it really has been a pleasure to be part of what has been an amazing journey so far. So I'm really excited to kind of share a little bit of that enthusiasm with the doctors in South Africa tonight. I've been working very closely with our partner Wright Milners in South Africa for the past 12 to 18 months now, and I have to say that I'm really pleased with the work that they have been doing to make such a difference for the doctors on the ground in South Africa. So I just wanted to say a sincere thanks to Mark, Chantal, Nikita, and the team in South Africa for everything that they are doing and will continue to do for the doctors in South Africa.
Thanks, Peter.
In the future. So I'm going to hand over to Dr. Federico, who is Dr. Federico Migliori, who is an Invisalign speaker and an orthodontist from Italy. He is a member of the European Board of Orthodontists and has been an Invisalign speaker since 2012. So what that entails is he can elaborate on, but I want to say a massive thanks to Dr. Federico for joining tonight. I'm really excited to have him as part of our journey for the orthodontists in South Africa, and I will hand over to Dr. Federico, who will introduce himself further.
Thank you so much, Peter, and welcome everyone. It's for me a great pleasure to be here with you. I want to thank Wright Milners and Chantal and Mark for the invitations, together with Peter from Align Technology. And I will start now sharing my screen just to start the let's say the presentation and introducing myself. First of all, as I said, it's let's say even a bigger pleasure to share this webinar with doctors from South Africa, because let's say it's a country I've always been quite linked to, not only for, let's say, amazing experience during vacancies. Okay, like it was 7 years ago, spent more than 3 weeks and 3,000 kilometers driving around the country, your wonderful country. But also, more particular, I'm let's say sailor, and I spent few weeks back in 2009 in Valencia because I was on the supporting boat at the America's Cup for Shoshaluza, and so that was kind of very let's say created connections with your wonderful country, and so that makes for me even a bigger privilege to can, let's say, share with you this time together. So I know you already know these wonderful views, so let me show now what are my views here in Italy. So this is the region where I'm from. It's called Le Marche. And I usually like to show some pictures of my region because I know it's nobody knows the market, unfortunately. And it's not on the touristic path of Italy. Everyone goes to maybe Tuscany, Rome, Florence, you know, and Venice. But my little region is becoming quite more popular, especially from people from Northern Europe, from UK, from Netherlands, and also Scandinavian regions. And in fact, last year we were awarded as the second best region to visit in the world. Unfortunately, we won that, let's say, award in 2020. That was probably the worst year in recent history for traveling. But you know, it's very similar to Tuscany. We're just next to Tuscany, South Venice, okay, on the Adriatic coast, and we have this, you know, countryside, small towns, a beautiful seaside, and my town, the city where I live, is something, let's say, quite small. It's called Fano, just 70,000 people. This is where I live today with my family, with my wife and my 10-month-old son. I've been, let's say, traveling quite a lot. If I go back to my, let's say, orthodontic background, I had my residency in the north part of Italy, at the University in Subria. You may have known Marco Rosa, Alberto Capriolio, Giuliano Maino, Mauro Cozzani. Let's say that in Italy and in Europe are quite famous names, or quite, let's say not quite, but great orthodontists. So I had an amazing school. But I have to say that obviously today we're going to talk about aligners. And my path, my journey with aligners was something that was kind of a homemade. The university, we were not treating patients with aligners. This has been kind of a personal passion from the very last years of dental school, because I was already in love with orthodontists. That was what I wanted to do. And on the other side, I'm like, love technology, innovation. And so there was something that always felt, let's say, the potential. I like the idea of a digital setup. So I can honestly say that I learned orthodontics with also the aligners. It was kind of doing the two things together. So I was learning orthodontics, and at the same time I was immediately kind of applying it to what was the Invisalign word back in 2008. Because at the end, I can admit that I did my first clean check before starting my residency in orthodontics. And I've been traveling in the US quite a lot in order to learn from, you know, much more experienced speakers. UCSF, I've been quite a lot in California, and I've been also Kentucky University. So let's say I've been traveling quite a lot. And what about today? Where this journey bring me is that now I switched almost all my cases to Invisalign. Why almost? Why I cannot say 100%? Because my other, let's say, field of interest, if I can call it like that, is dental sleep medicine. And my father is an ENT doctor. So that's, let's say, a passion that I got from him. And so I do a lot of mandibular advancement devices, but for sleep apnea patient, okay, not that. And also I use a lot, obviously, of RPEs. So we don't have to forget about that. If we need something skeletal, of course, we're gonna need to use those. But whatever is brackets and arch wires, I switched with aligners. And I started, now it's been 6 years that I, let's say, only rarely do something with fixed braces. And the other part that was my goal, I really liked that and was looking forward to that I finally can say to have a fully digital orthodontic practice. Obviously, you heard from Peter that I became an Invisalign speaker in 2015. Now, becoming a speaker, it was, I can say, just the beginning of my let's say, of the evolution of how to treat my patients with aligners, for two reasons. Because I will show you how much the system has changed from 2015 to today. It's been a huge improvement. And I can say that nothing that was there before 2015 is the same. There's no one thing. The only thing is the smart track, that the aligner, okay, the material of the aligner that was introduced 1 year before, okay, in 2014. All the other things has been changed, innovated, getting better. So, and the second one is that obviously becoming a speaker, I had the privilege to work with amazing orthodontists with an amazing experience with speakers, with Invisalign, and that helped me a lot into growing, into hearing, you know, specific topic with aligners, into improving my clinical skills with this technique. Because that's going to be one of the messages that are going to get out of the, let's say, hour and a half that we're going to spend together. That obviously everything is linked to our experience, because I'm going to show you a lot of biomechanics. I'm going to show you a lot of orthodontics with aligners. But at the end, obviously, this is a new technique, has its peculiarities, and we have to learn those things. We have to get used. Sometimes we have to kind of be forced to do a change in our mindset, because the approach is different to what we are used to do with fixed braces. We cannot approach a treatment with aligners in the same way. And now, you know, we call this event the Great Debate, okay? And so, again, I want to underline the fact that we want to have your interactions, okay? We absolutely need questions from you. That's the purpose of this meeting, is to try to answer some of your doubts, some of the, to try to understand some problems you had in the practice, something that you got very often, something that happens just once, how to deal with compliance, could be anything that bothers you into using aligners and that you cannot get solved. So,
Dr. Federico, can I add to this?
Yeah, sure, please.
I just, because I had some connectivity issues at the start, but
yeah, now we can hear you clearly, Peter.
Awesome. Okay, great. Yeah, thanks so much for highlighting this, Doctor. You know, tonight is the night for the orthodontists in South Africa. We have an amazing opportunity for you to challenge an Invisalign speaker with a fantastic amount of experience, and we have done a lot of work, and we've taken the time out to listen to your concerns and gather your questions, and that is what tonight is about. We have taken a certain number of questions which we'll go through, and then we will really open up the floor, because we want to challenge you, doctors, tonight, and we really want to ensure that you walk away with a much better and more open minded understanding of what Invisalign is, and what clear aligner therapy is, and what the future of orthodontics actually is going to look like.
Thanks a lot, Peter. So yeah, I wanted to, I know you had some connectivity issues, so I was going to exactly highlight this part, because that's the main purpose of this meeting. So please feel open to feel free to ask any questions. Okay, the interaction is going to be the main part. So let's say that my let's call lecture is going to be just the base, okay, the background of the this meeting, just sometimes a way of taking some ideas, or maybe giving you some examples of what you may face, and what we would like to know from me. So, well, what is the most common questions that we have been here for years? What Invisalign can do today? We talked about an evolutions, but most of the times that what we hear, what the system can do nowadays. And I may start answering these questions in many ways. I may start showing you all different malocclusions, very severe malocclusions, and I may start showing you. You see, you can do everything. You can treat any kind of malocclusions. You see, open bite cases, we will start from that. Looks super easy to be treated with aligners. Severe class 2, that's something of the topic that I like the most to speak about, especially class 2 in teenagers. So that's probably more than 50% of the treatments that I do today. Then you can go to transversal discrepancies. You can go to very challenging malocclusion. Look at this. I mean, class 3 with the posterior crossbite, open bite, these are obviously kind of surgical treatments. So if you look at this pre and post, is obviously what has been my experience. But again, as I started saying that I almost grow up using aligners from, let's say, my day one. And I can say that I'm more than digitally born with orthodontics, because I actually started doing digital setup before knowing anything about orthodontics. So that was probably too early. But I know what are the differences. And so what we will try to let you understand, or helping you to answer, is not what the system can do today, because I will give you what I think are the main aspect, okay, the main benefits that you have to that you have to consider. But our goal is to help you understand what could you do today with Invisalign. Because the first thing you have to remember is that we're talking about orthodontics. Everyone today here has most probably a different background, different university, different experiences abroad. And we're probably, if we want to take class 2 malocclusions, we probably use 25 different appliances to treat class 2 malocclusions. This is orthodontics. So the idea is to highlight how the system works and give you options that you can match, that can match your way of doing certain things, your way of treating some kind of malocclusions. And so in order to do that, that's why we decided to start talking about what are the myth and truth about Invisalign. And you know why this aspect is still very common to discuss about these things, is that the system itself has had a huge, let's say, a long history, because we're now talking about 23 years of clear aligners for Invisalign. And obviously the evolution has been very, very important. So what was true in 2005 when Invisalign reached its first million patients treated, it's most probably not true today. 2 million, the same. We were at the G4. Few months ago was introduced the G8, the generation 8 of innovations. So there are many concepts that we still have from how the system was working in the past, but now has been solved. But obviously we have to see the difference, and sometimes we have to approach the system in a different way in order to take advantage of the innovations. Because what I see many times, and there are still a lot of schools also in the US, actually in the US, those are the worst for that. They still use to change, for example, many attachments. They still use these big conventional attachments that nowadays are actually not needed 80% of the time, because we have better, bigger, optimized attachments that works better in combination with the Smart Track. So that's the idea. And just to give you some numbers about the evolution and what is the truth about, let's say, in this case, Align, just look at these numbers. Now there are 9 million patients treated. Actually, this was updated from 2018. So I guess that now we almost reached 500,000 aligners made each day. We don't need to know this to know how many aligners Invisalign Align technology make every day. This is just to say how much experience Invisalign has into working with aligners. And actually, this is what I want to highlight today, what is behind the treatment. That is the CleanCheck software and all the protocols that Align has been developing in the last, especially in the last 5 years, it's been a revolution. Now, what else? Obviously, 2021, we have finally a fully digital orthodontic system. And that's important. That's important not because now everything must be digital. We know that this misconception that everything must be digital. The digital aspect, the digital orthodontic system, I think it's very important for two aspects. Here, it's, I think, a revolution not only in the way we work, that our treatment planning is made on a computer in a proactive way, that we have a customized appliance. This is going to make a huge difference because this appliance is customized. And also, the communication with our patients is different, is completely different. And so we have to use these tools. And once we understand how to use these tools, you will really see the benefits of having a fully digital orthodontic system. This is not just cool because it's made on a computer. We want to see differences, benefits of using something digital. Otherwise, it's just a different way of doing the same thing. More than this, these are just few examples of the evolutions. Align focused a lot into giving us better optimized attachments, okay? More attachments that helps us having more predictable movements, because at the end, that's what we want. More options that are coming in the future. And the last two innovations that we had last year, actually, some are a few months ago, like the new CleanCheck Pro 6.0 and the Invisalign G8. Just to tell you 2 words about this. The CleanCheck Pro, apart that I'm a Mac user, so finally I don't have to install Windows on my computer. That's a benefit, something we've been asked and waiting for a long time. But the most important part that I'm using now on a daily routine is this, the in-face visualization. The in-face visualization is just an amazing tool that I recommend to use for every single patient. And it's a wonderful way of not only communicating with your patient. Think about that. Here you can show the smile at the end of the treatment and look how natural it is. Okay, the machine learning that's behind it, it's amazing. But also is the fact that we can work together not only on the occlusion, but finally also on the smile arc. So you do one movement on the teeth and you see immediately how the smile is changing accordingly to that movement. So today the CleanCheck is not just a communications tool, but it's really an amazing, that can be diagnostic tool, and for the treatment plan, there's nothing better than what you have here, all the information that you can get. Now let's talk about something more clinical, just to give you the last example on the innovations. Let's focus on the G8. The G8, this is something that will change and we will all use a lot, especially for the expansion. So this is a concern that when we expand the upper arch or the lower arch, we tend to have more buccal tipping, okay, than bodily movement. So we knew it was, I have a lot of lectures about this, that we had to add attachments on the buccal surface in order to control, as you see here, to control the root torque. But now this is going to be automatic. This is going to be pre-made. This is a protocol that when you expand more than 0.5 millimeters, it's going to be automatically placed. And something even nicer is that, okay, but I also have a rotation. Well, the software is going to rotate that attachment accordingly to the rotation you're planning. So this is how precise now all the new optimized attachments are. And this is something that increased the predictability. And it's not only that, it's less work that we have to do on the software. Because I honestly, this part in all my courses was at least 30 minutes to let doctors understand what they had to do in order to control it. Because you know what? This is another topic we may discuss in the Q&A. If you don't control the expansion, this is what you got. The posterior open bite. This is part of not having a perfect settling on the posterior. We knew that. It's like if you take an arch wire, you overexpand, this is what you got. It's the same. You got buccal tipping. Now, with the G8, this is going to be much more common to be seen, because at that point, those attachments are going to keep the control of the tipping. Is going to give us a better bodily movement. So these are just obviously few things that have been developed. The list is very long, but the final part is just to show you that with this system, we have to work together with what the software is doing. This is part of dealing with AI. I know that it could be, you could fear the fact of dealing with the computer, but at the end, whatever Align is doing is to help us having a more precise treatment planning, giving us more information to make the right choice in our treatment planning, because it's our choice. We have to decide what to do with the software. Remember, the software by itself, it's only leveling and aligning if we don't say anything else. If we don't give them references, they just do it by themselves to align and leveling. And so in case we may not like how they aligned and leveled. But about closing a space, distalizing, extractions, it's our prescriptions that give them the treatment plan and what you see on the screen. So it's our job to take care of it, to control if actually what we asked, once we have the numbers, it's really realistic or not. Because what the software is doing is helping us with a lot of clinical rules. You see this, 2015, that's why I have this year always in mind, because that's when Align changed completely and how fast the innovation were delivered. So 100 clinical rules, now we have more than 3,000. So everything we asked for intrusion of lower incisors, we're going to have a specific protocol for that. Now you saw with the G8, you are expanding more than 0.5 millimeters the upper arch, you have specific attachment, specific activation of the aligner. So this is everything that the software and this Invisalign system, because it's everything together, is doing to help us achieving a predictable result and a successful treatment. Now, obviously, we have to take one thing into consideration, that as any orthodontic technique, there's a learning curve with Invisalign. So you have to take all the knowledge that you have, all the, let's say, the biomechanics that you know, all the biology that we have learned, and put it behind the teeth moving on your clean check, because that's how to approach, to critically look at the clean check. We cannot just accept some movements that is the software is giving us. We can accept most of the attachment, we can accept most of the staging, but about, for example, the anchorages, it's up to us. So the software can say, okay, can show us fully maximum anchorage with extraction of upper 4, but the anchorage to that maximum anchorage, it's up to us, for example. So this is something we have to always keep into consideration. Now, just a few words before starting giving you examples. It's how the system works. how the system works, and I want you to remember it. This is one quote from Professor Melson. Okay, that, you know, Professor Melson has nothing to do with aligners, but exactly that's for that reason that I use this quote. Cells don't know the name of the appliance you are using. So every time you look at teeth moving on a clean check, every time you look at a digital setup, you have to remember that here I call it digital biomechanics. You're moving teeth. So everything that could be very complex to be treated with brackets and arch wires, maybe it's difficult also with aligners. But there are going to be some biomechanical differences, and that's what I want to highlight also to open the debate. Because there are things that are easier, much easier, to be done with aligners. So it's not about limitations. It's also about advantages. It's a different tool. And obviously, with experience, you can obviously overcome also the limits that sometimes the system has compared to fixed braces. Okay, so remember about this. Every tool has specific advantages or limitations. But once you know a tool, you're going to use it for everything. And now we are at this stage with aligners. So digital biomechanics, this is what it means: dealing with forces, tooth movement, anchorage, and side effects. But doing it proactively. So you're going to put all your knowledge, not during the treatment, but on the computer. Because during the treatment, it's going to be more, I call it orthodontic common sense. You're going to use some troubleshooting from auxiliaries. That's what you do. But all the treatment planning, the biomechanics, the anchorages, you have to set everything in advance on the computer. So this mindset, this is the change that we have to make. This is not just starting with the treatment and try to modulate the use of the aligners during the treatment. It doesn't work. We have to spend some more time on the software, and then it's going to be, then the benefit is going to be much less chair time, shorter treatment time at some point. Okay, and I'll give you examples in order to compensate, let's say, the extra time that we're spending on the computer. Okay, before starting to check the first two cases, actually it's going to be one in mainly, let's say, one case about open bite and highlighting the biomechanical difference. Let's see if we have any, let's say, questions about the audience or something we want to highlight. So we're going to do breaks, okay? Don't worry, we don't want to leave everything at the end as a Q&A session. So we want to be open throughout the entire webinar.
Thanks, Dr. Federico. Can you see the questions, or would you like me to read out a question which has come in from Dr. van der Merwe?
No, okay, I can read it. I mean, if we have, do we have the facility, right, to do these, the changes seen in the face? Okay, absolutely, yes. There is, just to technically tell you how to do it, it's very easy. We have to take one extra picture with the cell phone. The only thing is that we have to take that picture that you saw there, it's taken from a cell phone. Okay, now with lights and the cameras, it's like they're super nice. But if you want, you can take all the pictures, but we know, at least me, that I also love photography. I always want to use my professional camera to take the pictures. But in case, you just have to put the name, okay, like register the name of the patient, and you have to take one picture of the smile of the patient, and then you upload that picture. Once you have uploaded it, you do your prescription for, as you have always done, okay? And then what will happen is that Invisalign is going to match your scan, iTero scan, with the picture you took with your cell phone, and you're gonna have that simulation. The great part is that it's automatic. I've been on all the beta tests of a DSD with Invisalign and etc. I used it, was absolutely nice, but it was a lot of work because we had to do 2 different clean checks. One with DSD, with the technicians in at least here in Italy, we deal with Madrid, and then another one with Align, and then they could match the DSD and the clean check. Now it's automatic, and honestly, it's much nicer. It's much nicer to show to the patient. The DSD, it was too digital, okay? Sometimes I could not even show that to the patient because it didn't look that nice. Okay, this is something, the other question is about, I think, the MA, okay? So I don't know exactly when you are going to have that in South Africa, but I think we can leave that for maybe Peter's, and we may give you more information about that. But I think I can give you some other options that we have using elastics that are really interesting later on.
Thanks, Doctor. So just in relation to the mandibular advancement, this will be coming later this year, Dr. van der Merwe, to South Africa, along with some additional innovations also.
Okay, wonderful. That's a great news. Okay, so let's start seeing something about open bite. So open bite, just to make it the story short, treating open bite cases with aligners has the greatest biomechanical advantage over fixed braces. This is something I say also for doctors that are just taking their certification. Whatever open bite case, it's going to be easier with aligners than with fixed braces. So even if it's a complex malocclusions to be treated, it's going to be easier with Align, with Invisalign. So the indication here is not eye, it's very eye. You may start doing all your open bite cases with Invisalign because of this, because of, let's say, the tendency of having a much better vertical control. Then here we're going to need time to go into what we have to do to have the bite block effect or not. But let's say that the vertical control that you get is just amazing. Just one example. Here I'm going to do some pre and posts fast and then go more deeply into another case. And here I'm going to do just a pre and post to show you this case. This case is quite old. Actually, I approved this clean check in 2015. And look at how open bite it is, how hyperdivergent it is. And if I have to say that I go back to my, let's say, residency years, okay, these cases were all surgical treatments. I actually showed this case to my chairman year after, okay, and it was still, yes, that's a good compromise, that's a good compensations, but obviously that's a surgical treatment. It's never going to be stable. Actually, from what we know today, if we carefully plan a good balance between extrusion of the anterior, okay, look at the malocclusion, and intrusion of the posterior, you can have a very stable result. And now with the in-phase visualization, you just plan everything accordingly, okay? You extrude the anterior in order to have a very pleasant smile without exaggerating, without asking too much extrusion, because we know it's not even that stable, obviously. And you decide, biomechanically speaking, how much intrusion you can achieve on the posterior. And I wanted to show you this because today I would probably change the majority of those things. You see how many conventional attachments I have, no attachment on the posterior. There's been obviously an evolution also to how I approach these cases. But even there, the biomechanical advantages were that great that had an amazing result for me, even with not that much experience. And you see, the idea is expanding with the aligners, okay, no elastics. You intrude the posterior using, let's say, the bite block effect. And the only thing that I think I did it quite right at the time was planning that then became a protocol that I use on a daily routine is this: triangle elastics. Those triangle elastics, I saw that help me a lot into, let's say, achieving the posterior intrusion, okay? I'm kind of forcing the patient to bite on the aligners, okay? This is just to give you the biomechanical reason why I'm doing this. And you see, it was not a crazy intrusion, okay? Look at how many movements or how precise everything is set. Here it was 0.5, 0.7. I planned kind of a 1 millimeter, no more on the posterior in total. But even with that amount of intrusion, that was not much, you see that I could have that what we call vertical bite jump. That's just a simulation. We know if you intrude the posterior, you know that you're going to close the bite. And that's what I was looking for in this case. You see, this is November 2015. This is when I approved this clinching. And just to tell you that in 16 months, after one refinement, this is what I reached. From ear to ear. The only auxiliaries that I used, it was a bottom ear, and then at the end I almost also changed the way I was doing the other things. That was with triangle elastics. This is the smile, the most rewarding part of treating these cases. But what I found, you know, I came from, okay, all these cases are surgical. Actually, studying more and learning orthodontics, I found that on meta-analysis, there are many, many studies, also scientifically speaking, the highest that we can have, that tell us that a good compensation with extrusion of the incisors and intrusion of the molars can have almost the same stability long-term than a surgical treatment. So for me today, seeing also how easier it is to get these results and how stable they are. This is the last pictures that I took 4 years after finishing the treatment. Okay, that's why I wanted to show you this. Is that the long-term stability of the overbite for surgery is on average 83%. So you achieved 5 millimeters of correction of the overbite. You still have 83% of those 5 millimeters after 5 years. Do you know what is the average if you don't do surgery? It's 75. So we only have 8% of difference. And that's not something that for me today make me decide for surgery or not. For me, if it's only occlusion and smile, I will go just with aligners. But if the patient has a big asymmetry, obviously chief complaint is the profile, then I cannot do that without the help of our surgeon, okay? And so those are the cases that I treat with surgery. But now, obviously that was just a pre and post. But I want now to show you something that we face much more frequently. Those are very severe open bite that sometimes we have. But let's say that something that could be much easier, and I want you to show the efficiency, how easier it is to treat these cases with aligners. Look at this malocclusion. Definitely easier than the other one, right? We have some crowding on the upper and the lower. Open bite on the anterior, yes, more severe on the right than on the left, but I think you all agree that it is a much easier case. But we know that is at the end with fixed appliances, these are never easy, never, because you have to extrude those incisors. Trying to intrude the posterior without mini screws is just obviously impossible. So these are always difficult treatment to be done with brackets. Now let's finish this. Okay, this is the OPG. This is the SEF, obviously a minor open bite, but you see there's also this kind of a reverse smile. Here we could extrude the incisors, but look at the clean check. This is a much more recent one. We have 26 aligners and the vertical bite jump. Here you can be realistic. You see how much you are intruding. You see the triangle elastics that now I'm always using. Attachments on the anterior, I place them palatally for aesthetic reason. So you give something to the patient that it's really aesthetic, much more comfortable than whatever other kind of appliance you can place. And you have 26 aligners. Okay, 26 aligners. It's almost, let's say, nothing to compare to what could be the let's say the average treatment time with fixed. And just to give you a reference, we can expect, there are many articles, but they all say that it's around maximum 1 millimeter of molar intrusion with aligners and elastics, or no elastics and sequential intrusion. So that's a realistic movement. Please, I will say realistic many times because this is essential. That's the first thing, the most common mistake that I've seen from other colleagues, even very experienced and sometimes I can say famous orthodontists here in Italy, that they just got lost in front of a clean check because everything looks easier. But we have to remember about how is it possible to achieve the realistic movement. But the good news is that with 1 millimeter of molar intrusion, you can achieve, we know, a bite closure of easily 2.6 millimeters, 2.5, sometimes 3, as Profit says. And so, just to show you the sequence, 4 months, aligner 12, aligner 26, this is the end. 7 months of treatment. I guess the treatment is finished. I did a refinement because I wanted to do my finishing. This is how we have to use the refinement. The additional aligners, I know now I call them additional aligners, but for me, it makes much more sense to call them refinement because this is how I use it. This is my finishing, as you have always done, I think, with fixed appliances. Because the straight wire does not work 100%, absolutely not, because it works on average. Here, it's kind of the same. We know it's always more predictable, but 100% in medicine, I'm sorry, it's going to be hard to reach 100%. So it's going to be part of software improving, our experience improving, overcorrecting something that you know it's more difficult to be accomplished. But at the end, if I had to this treatment 2 months of refinement in order to reach these kind of occlusion, look how settled it is. And if I compare to what I planned, everything, it's very close. Actually, it's almost the same, except look at this. This is an overcorrection because I know that the torque expression, it's quite challenging sometimes because of the flexibility of the aligner. And that's what I do. I overcorrect the torque. But how many times you have given extra torque to your stainless steel arch wires? How many times? That's the same. The only difference is that here you do it in advance. You do it before starting the treatment. So the pre and post, 9 months of treatment, look at the overjet, look at the settling difference that we have on the overjet. This is the OPG at the end, and you see the SAF. You see mainly it was 0.4 on the upper, so not much. Some extrusion of the upper. On the lower was almost the same. We had some extrusion of the lower incisors. And here, this was the digital smile design old style. Okay, doing it with Keynote. But it worked, okay? So it was just to give us an idea on how much I could extrude in order to have a nice smile. And so this is the before and after. And here I only have 1 year after the treatment, except the very bad oral hygiene, but I saw them 1 month ago and I wanted to take anyway the pictures. But you see, everything is stable. And if it's stable after 1 year, it means that it's going to be stable. Okay, you see the only difference is there, but we can say that the occlusion and the settling is still there. Okay, Peter, I think we can do another break, try to talk to see if doctors have any questions.
Perfect. We have some questions from Dr. Petra with regard to some of the cases that you've just presented. So the first question, excuse me, the first question is, or comment is from Dr. Petra. I do a lot of posterior intrusion, which then open the bite at the back, which causes anti-clockwise rotation of the mandible. Will the technicians understand to do a rotational bite jump?
Absolutely, yes. That's actually what that's the main aspect of correcting these cases. Okay, obviously there's going to be a counterclockwise rotation. Okay, of that's all the studies show us that. Okay, counterclockwise rotation, and so you have, let's say, the bite jump is mainly vertical, but you can ask to the technicians to have more. Let's say also some kind of an advancement, but you can adjust accordingly to what you want to see. Honestly, with experience now, I just leave an extra overjet because I know that the bite jump is not going to be only vertical, but it's going to go also forward. So that's part of the experience of the bite jump, but that's exactly what you're taking the benefits from. Okay, so if you want to see it exactly how it will be, you can ask to the technicians to be more precise accordingly to, let's say, your knowledge. Otherwise, if you don't want to start, making all these modifications to just visualize something different, you know that the mandible is going to go a little bit forward, just leave an extra overjet so that, let's say, that the space can accommodate the counterclockwise rotation and slight advancement of on the mandible. So absolutely, yes, that's how to plan the case in advance.
Great, thank you. And the second question was, will you achieve 1 millimeter of intrusion with aligners only or with the help of auxiliaries?
Okay, here there are two ways, and that's a very important question. So that's why we're asking, because obviously we cannot go deeply into all the aspects, but with the question it's going to be much easier. Two ways. Without anything, it's rare that you obtain, without auxiliaries or specific staging, it's not that easy to obtain 1 millimeter. Why? Because it depends on if the patient is a clencher, how strong our muscles are, because obviously we need a lot of force to intrude the molars. So what I do, my approach is to plan the triangle elastics. So what do I mean? I mean that the triangle elastics, as I said, force the patient to bite on those aligners. Okay, the thickness is 1.5 millimeters, and so I'm forcing the patients to let's say give some force on those molars. So otherwise with big attachments there are some different protocols to have a sequential intrusion of the posterior. Honestly, you may have heard Sandra Tai talking about it. I don't know if you know her, but for me it's too time consuming, because if you change the staging, this is something I don't like doing. I do only for example, extraction cases that are the more complex one. But for this, I think that using by night or 12 hours per day triangle elastics for 3-4 months, it's much easier and more efficient than to increasing by 50% the number of aligners, because when you do different staging, you increase the number of aligners. But that's an active way of trying to achieve the 1 millimeter of intrusion. So thanks for the question, because yes, if you want to reach the 1 millimeters, you have to do something else. Then it's up to the patient. I was shocked last week, Friday. I saw a patient after 8 aligners that the bite was almost completely closed after 8 aligners. But then I was curious, because usually it's not that fast. So it was after kind of a 2.5 months. And muscles very strong, okay, big clencher, that it's kind of a rare for hypodivergent patient. So you see, the muscular pattern also makes a difference in how much bite block effect you're going to achieve.
Thank you, doctor. Okay, at this stage we don't have any more questions, but I see Dr. Hugo is asking what strength triangular elastics.
Okay, very well. It depends if you're using only by night. I tend to go very strong. If it's by night, I do 1/8, 6 ounces, 6 ounces. So strong elastics, like small elastics. If it's only by night, if the patient is more like we're talking about teenagers, they're open to wear those elastics also during the day. I tend to use lighter forces. I tend to do 3/16, but always strong forces. Okay, so always 6 ounces. Nowadays, I mainly use 2 elastics: 1/8, 6.5 ounces, and 3/16, 6.5 ounces. That's mainly what I do.
Thanks, doctor. The next question that has come in is, with these types of cases, you mostly have to expand the maxilla as well. Do you stage expansion and intrusion, or do you do it simultaneously?
Okay, great. I see we're going into details. Thanks. And most of the times I do that together. It's like distalization and expansion. They work very well together. So you don't have to do a different staging. What you do differently is the use of the auxiliaries. Okay, you saw that on the first case. This one was easier. So it's everything together. But on the first case, okay, just go back quickly. Okay, you have this. Obviously, you cannot close the bite in cross bite. So here, you don't do different staging. Different staging means you ask for first expand and then intrude. You're going to have, instead, here I had 42 aligners. I could end up easily with 60 aligners. Don't do that. You are going to be the one who stages the movements differently. So at the beginning, you saw that, I mean, here there's no the other controls in the middle, but I just focused on the expansion. So I just continue giving the aligners to the patient and check the tracking. When the upper arch was mainly corrected, I focused on the vertical with the triangle elastics, but I didn't increase the number of aligners because the patient is always biting on those aligners. So you kind of have that bite block effect entirely during the treatment, during the entire treatment. So it's you that with the auxiliaries, you focus on one thing or another. So that's how to handle it. So let's say if you have a posterior cross bite, use cross elastics first. When you corrected the cross bite, you use triangle elastics. That's the sequence.
Thanks, doctor. Okay. So no questions on the chat just now. I'll take this opportunity to highlight some of the questions that we gathered from the doctors who are online. So, Dr. Federico, for your knowledge, some of the doctors are trained providers. A small portion of the doctors online are trained providers, but a large portion of the doctors are not trained in using Invisalign. And I think this is a key part of tonight's session, is to really allow those doctors also to give us that input and challenge us as well. And some of the input and the questions or concerns that came out of the market is what I will raise now, and maybe you can elaborate. So I'll just start off with some of the challenges that we've heard from doctors. So one of the challenges was that Invisalign is an orthodontic system with limited capabilities. From a finishing perspective, I'm not happy with the finishing that Invisalign gives. Invisalign doesn't result in good posterior occlusions, as well as final alignment is not achieved with final alignment is not achieved with Invisalign.
Okay, so let's try to, thanks for the questions, and let's try to do step by step and try to answer and highlight some of the things that I think are more important. in order to, let's say, overcome those issues. So the first thing is about the limited capabilities. So at this point, I said that, you know, Invisalign aligners are a different tool if you think about the aligners itself, but the CleanCheck software itself is not about, you know, the capabilities. That's a completely different approach to how we are used to do our treatment planning. Okay, and so that's the one that needs the change in our mindset, let's say the CleanCheck part. But on the biomechanics, this is part of having aligners instead of brackets and arch wires. So I can honestly say that sometimes it's actually the opposite. It's not about limitations. I started with open bite because that's exactly the opposite with open bite. That's not limitation. Actually, here we have a lot of advantages over fixed braces. Whatever you do, you're going to close the bite. But for example, you want to take the opposite. You want to open the bite and extrude the molars. Biomechanically speaking, I cannot say it's impossible because there are ways and features that we have, for example, with the G5 for the deep bite corrections that help us achieving the extrusion. But we have to work a little bit more on the extrusion of the posterior than with fixed braces. That's a different biomechanics because we are using aligners other than fixed braces. Extraction cases, it depends what we have to do. There we have less protocols, but honestly for me with experience, that's not a limitations. It's just that if you tell me, can I start, I have zero experience, tomorrow I want to do an extraction case. It's like for me, if you tell me, do you want to do tomorrow an extraction case with the lingual appliances? Please no, please no. You know, I know Giuseppe Scuzzo very well, and he's a magician with lingual appliances, but I know that's probably one of the most difficult technique that we can have. So in his hands, everything seems very easy because he has an amazing experience and he is an amazing orthodontist. But for me, that I would be a very beginner with the technique, extraction cases are always the most difficult ones. So honestly, today's I see differences, absolutely, but regarding then the treatment, the patient experience with the treatment, that's why I started. I fell in love with aligners because finally we give a much better treatment experience to our patients. I see mostly potential and benefits. For the settling, I guess that the first two examples could tell you that in these cases you have no problem of settling. Probably the doctors were referring to the posterior open bite. Now, just to make it clear, I think that at the beginning I gave you one example to answer to these questions. That is the posterior open bite because of expansion, uncontrolled tipping of the molars while you are expanding the upper arch. That's one of the reasons. But this is part of the myth, because today that's what we're talking about aligners. That they intrude the molars and you always finish your cases with a posterior open bite. Today we know that molar intrusion, that will be amazing to have that problem in any case, because I just show you that you have to do something if you want to have 1 millimeter of molar intrusion. You have to be active in your treatment planning, in your using auxiliaries, attachments, and etc. if you want to have that. So it's not that easy to have that intrusion, unwanted intrusion and posterior open bite in your cases. Most of the times, the posterior open bite, I can say more than 80% of the time. I review thousands of cases a year, thousands of cases. And most of the times it's because there is a premature anterior contact. So my suggestion is, if you don't like the posterior occlusions, there are two options. You first go check premature anterior contact. If there are no premature anterior contact, it means that actually that slight space, but be very minor space, is because of molar intrusion, because of the thickness of the aligners. But the best part of seeing it is that the solution is just doing nothing. You just have to wait. There's Tweed called them recovery phase, okay? Because if you intrude something and you don't keep something to maintain that intrusion, the teeth are not going to stay year and year. They're going to go back, and you're going to see that settling automatically. You don't have to do anything. Sometimes you may cut the posterior, but really, I've done that into 10 cases in 15 years of experience. You don't need that. Most of the times, you're going to see that there's a premature anterior contact. Why? Because you didn't obtain the intrusion you planned, because you planned 3 millimeters of intrusion and you didn't see that was probably too much, and there was not enough anchorage for that intrusion. So instead of 3, you achieve 2, and you have a premature anterior contact. Or I showed you the torque. You are retracting, you lose torque, and you have a premature anterior contact. So there are many situations where this premature anterior contact gives you the posterior open bite. So just to make the story short, remember, you never have to approve a clean check with already heavy occlusal contacts on the anterior, because if you see them on the clean check, for sure, you're going to have more clinically, okay? So that's how to, let's say, solve the issue. It's not because of the aligners. It's not because of the molar intrusion most of the times. Most of the times, it's because something went wrong on the anterior. And the solution is obviously different, because you have to solve the anterior and not the posterior. Otherwise, now I feel the opposite, because this is a customized appliance. And again, please remember that it is a customized. You don't have to move all the teeth. The 80% of my clean check reviews with doctors is reducing movement and blocking molars movements. You don't know how many times there is already a good settling, an adult patient with a class 1, and the software, if you don't say anything, is going, for example, to intrude the lower 7 and extrude the upper 7. Biomechanically, it's not possible, but for the software, it works ideally on the leveling of the arch. But that's our job to remember, wait, this is not fixed appliance. I don't have to move. I'm not forced to move all the teeth. Just keep it stable. This is the first lesson that I learned. I now, one of my main topic is asymmetrical cases with Invisalign. And that's the first lesson I learned from Dr. Boyd in California many years ago, that one of the best benefits, one of the biggest advantages of aligners is to keep stable what is already good in an occlusion, in a malocclusion. There's always something good. If there is, keep it stable. Don't move those molars, don't move those teeth, and you see that you're not going to have these problems anymore. Sometimes it's just that we're moving too many things, we don't see that, and so we create some premature contact, something that makes the occlusion unstable.
Thank you, Doctor. Okay, I see Dr. Petra has, she wishes to add a comment. Dr. Petra, I'm going to invite you on to the stage.
Hi, Peter. Thank you so much. No, actually, I don't really want to get onto the stage. I've just put in the chat my experience with Invisalign, and I agree with Dr. the doctor. For me personal, the finishing that I can get with aligners are superior to fixed braces, because you cannot tweak individual teeth where you are limited with a prescription in the brackets, and you can't change the individual torque easily with your limitations on the prescriptions, where if you use your clin check, you can, to the millimeters or to the points of degrees, look at your buccal torques, at your finishing, at what makes a case finish properly. And you can, with all the facilities that you've got on your clin check, it blows your mind away. You can do literally micro-orthodontics, which is impossible with fixed braces. And I'll stand and I'll die on that. That's all that I wanted to say about that. But the thing is, you must be prepared to spend time on your ClinCheck, on your software, and that saves you time in the clinic. If you do your treatment planning beforehand, the follow-up appointments is short and sweet and quick, and you just track your cases, and it goes well if you do your treatment planning well. Yeah, so it's very exciting. It's really exciting. Thank you.
Thanks for sharing, Dr. Petra. Really appreciate that. Thank you. Dr. Federico, do you have anything to add to that?
Yeah, thanks a lot for your feedback. I think you really got the point and the main difference of using in the proper way the ClinCheck, because when you start seeing those differences, you understand that actually, yes, you can focus on exactly all the small details. I like you use the micro-orthodontics, that it's almost impossible to have done. No, it's not impossible, but you need to be, I mean, your, let's say, manual skills level is very, very high, okay? And here you can set, it's like for, you know, all the spaces you want to leave distal to the laterals for the build-ups. Here it's so smooth. You just decided on the ClinCheck, you want 0.4, you want 0.5, and you have the bolt on there. So I agree, you have so many information that I see it easier to finish better my cases. I'm so used to all this information and data that really I'm struggling. Sometimes I have, you know, fixed braces. Sometimes they come to me at middle of the treatment because they're not happy with and so I still sometimes give it a try to continue with fixed braces, but it's, you know, the precision that I can have and the way I can plan everything in advance, it really makes, I don't want to say your life easier in your clinic, but that's it. I mean, your chair time, your workflow, everything, it is easier. Okay, so that's the way to approach it. And thanks a lot for your feedbacks and sharing your experience, because that's really important.
Very valuable indeed. Thank you. Okay, I will keep going to the next challenge that we received from some doctors. A comment we received was that additional aligners are always required, which means the treatment doesn't work.
Okay, that's a very important one. I always try to be as realistic as possible about my treatments, what I do on my daily routine, and how I use the system. I can honestly also tell you that I do not agree with the let's say, the approach of, let's say, other famous speakers that say that, no, we have 100% of predictability, you need not auxiliary, you need no refinement, okay, because everything is very predictable. I think that that's kind of a forcing too much how the biology of the tooth movement is and how the biomechanics is. Because as I said, I think that having a finishing with what we have just said, using the ClinCheck, the finishing, the refinement is blocking the majority of the teeth for me and just focusing on, okay, the patient still doesn't like 2.2. The patient still doesn't like that extrusion that, you know, I lost some tracking. It could happen, okay? We're dealing with human beings. As I said, 100%, it's never there. Think about the play of your arch wires in the slots. Sometimes you lose 50%. There are many studies saying that you lose 50% on average of torque expression with fixed appliances. 50%. But I know that when we go with aligners, being digital, everything seems, oh, there they had 42%. There they have 38. There they have only 60% of predictability. It's important to remember that we have to think about the efficiency and at the end, the length of our treatment time. I had to change completely, the payment methods of my patients when I started using a lot Invisalign, because I was finishing all my treatments way in advance. Because I was used, it's always 18 months, it's always 24 months. I had kind of a two-way of payment, and that was it. So I had a lot of problems for a couple of years, because I was kind of finishing 6 months in advance, 9 months in advance, because that's not part of teeth are moving faster. No, teeth are not moving faster with aligners. Actually, most of the times are moving slower. But at the end, because everything is more precise, pre-planned, you can see things in advance. The point is that you go slower, but you go straight to the final position. You don't have this opening, aligning everything, the patient is happy, but the occlusion is terrible, and then you have to go back, work on the settling, and you do 9 months of finishing. Here it's completely different. You go slower, more precise, more control, and then you do the additional aligners. So to me, that's the fact. One refinement, it's normal, it's my finishing. And just to tell you how much I believe in this, I included in the price of the treatment for my patients, obviously I'm not saying to do that, one refinement only, because I'm absolutely sure that if I have to do 2 refinements, it's because they're not compliant, and I don't want to keep going adding aligners. I don't do that anymore, because I know it doesn't work. If the patient, for whatever reason, at some point stop being compliant, I stop the treatment. I gave them a break. I tell them that you're going to be on vacation from aligners. And then I restart the treatment after 3 months, 4 months, 5 months. It works really well. I don't just keep going, doing clean checks, adding additional aligners. You have to understand what is the problem, face the problem, understand what's wrong, and address that. You need 1 refinement to do that. Then obviously it could happen. Sometimes I have 2. If I know it's something I did wrong, obviously they don't pay. But don't remember, last time I had to do more than 1 refinement. So remember, that's part of your finishing. That's how you have to look at the additional aligners. If you need 3 or 4 additional aligners, that was something, I say, wrong, or a wrong approach on the clean check. Too many movements, unrealistic movements, lack of compliance, a big lack of compliance. There must be something else, because otherwise you don't need that amount of additional aligners. I've done now more than almost 1,000 cases with the system, and I can say that actually this is how it is. Obviously, experience, it's part of using properly a treatment. That's what I said at the beginning. I wanted to start saying that, of course, but it's not true that it doesn't work because you need additional aligners. That's just not true in 2021.
Thank you, Dr. Federico. We have some questions that have come in the meantime, so I'll stop with my challenges, and let's answer the questions. So 2 questions from Dr. Hugo. How often do you use buccal and lingual attachments to achieve a force couple, for example, for buccal root torque of the upper molars?
Buccal and lingual attachments. Okay, buccal and lingual attachments, honestly, I think I never use buccal and lingual attachments, because you have to think, I want to go back to, because thankfully it's part of the G8, so I should have one picture very fast. Look at this. On this side, you have the aligner that now actually has a specific activation for the expansion, and on the other side you have a big attachment with a big active surface that gives you the buccal root torque. In case, sometimes I don't use 2 attachments, but if it's a severe crossbite that I want to solve, I do this. I do some overcorrection, because we know that the aligners are flexible on the posterior, like the arch wires are more flexible on the posterior. So you want to give it some extra expansion. And in case, I use cross elastics. So if really it's challenging, I do cross elastics plus the attachment here. I never do the 2 attachments, because I think that even if it's only by night, cross elastics are going to help you much more than the 2 attachments together.
Thank you, Doctor. And the second question, a reverse curve arch wire to intrude lower incisors has the side effect of intruding the molars unless up and down elastic forces are used. Do you ever use up and down posterior elastics to focus the intrusive force on the lower incisors in Invisalign?
Okay, actually, up and down posterior elastics. Okay, actually no, because I think that with aligners, when you do, I mean, the reverse curve SP concept, it's true, but the anchorage. Look at this picture. Actually, it's gonna help us too. That the majority of your anchorage for the lower incisors intrusion, or say the leveling, is on the premolar area. That's where you want to have the bigger attachments, some extrusion, okay? You're kind of forced to extrude there. So that part of the reverse curve SP is the one that makes sense. The intrusion of the 7, I mean, it's very difficult to go up to the 7 in order to really have the reverse curve SP. You can try to have some intrusion there, but honestly, I think that if you can have the combination of precision bite ramps on the upper incisors, even if it's only the centrals, extruding the premolars, if you can even extruding a little bit more the first molar, that's going to be enough. Obviously, we are not extruding them, or if there is some space, it's possible, but it's kind of it's a compensation of the intrusion of the incisor. We're just giving more anchorage to the intrusion of the anterior. So that's, let me say, if I can say, play your match if you want to solve or really, level a curve SP on the lower arch. So posterior elastics, honestly, this is something that I don't feel the need, okay, with the aligners. I think that this anchorage and the bite ramps are more important.
Thank you, Doctor. And one final question from Dr. Petra. Would it be beneficial to add bite blocks or bite ramps onto the posterior teeth for a bite block effect? Okay,
that's we can see you have some experience with the system. Okay, that's something that I've tried in the past. I absolutely think that it's not wrong, so it could be beneficial. Only personally, what I didn't like is that you cannot cover entirely the occlusal surface of the posterior teeth, and so I found that probably I was not lucky, and the patient was always kind of sliding from one side into the others, was not biting on the because what you say, the bite block or ramps actually are attachments, because you cannot add anything else on the posterior, because otherwise you can, if you have to add some composite on the aligners, it's kind of not worth it. Cutting the aligners and adding a bite block, some composite on the molars, it gives you lose a lot of anchorage from the posterior, so it depends on the movements you are doing. So honestly, I found that the elastics for me are the easier thing. Otherwise, just place some fake attachments. If you can place 2 on the occlusal surface in order to kind of make the aligners thicker. But 1 is not enough. Otherwise, the patient is just shifting right and left, and that's also could be painful for the TMJ. So, or you manage to place 2. Otherwise, I didn't find many benefits on doing that.
Thank you, Doctor. Okay, there are all the questions from the chat. Let's see. I think maybe one more has come in. Yeah. Okay. So another challenge or comment that we heard from some doctors is that a lot of IPR is required with Invisalign patients.
Okay, that's very common. And to answer, I can tell you that after starting to do many cases with aligners and getting experienced with with the CleanCheck software, I actually found out, I was at the beginning, let's say right after my residency, I found out that I was not doing enough IPR with my fixed appliances, with fixed braces cases. So the idea is that I know we always have a lot of IPR. We always know we have IPR on the CleanChecks, and I was not used to do IPR that much on my cases with fixed braces. The fact is on the side effects of the fixed braces. What the NITA is doing is expanding and proclining. We're fighting the proclination of lower incisors. And we do the bend backs, the lace back. Every technique has its own way to dealing with the proclination. But at the end, you do that, and then you see that, no, maybe these are too proclined, and then you do the IPR, and then the power chain. Here, if you don't want to do IPR, so if you think that the software tells you to do too much IPR, just block the software into telling you to do the IPR. It's on the prescription form. On the prescription form, remember, this is a customized appliance. The software is not telling you to do anything. It's you asking the software. It's a big difference. So if you don't want to do IPR, on the last part of the prescription form, you ask no IPR. No IPR on the lower, no IPR on the upper. You're not going to have IPR in all your cases. You can actually ask for no IPR in your first CleanCheck if you don't like it. But I promise that if you try to do it, you will then add manually with the 3D controls the IPR, because that's it. There are only the ways to achieve some space to solve the crowding are expanding, proclining, IPR, or extractions. We do not have anything else. So you will see that sometimes it's not enough to only do the proclination. I mean, it's just you're proclining too much, and so you will add the IPR. But if you want to do something in between, like I do, you may write on your clinical preferences that you want maximum 0.3 millimeters on the anterior, or that you want maximum 0.3 on the posterior and 0.2 on the anterior. You want to be more gentle, absolutely fine. It's your choice as a clinician. So we have to, get away from all those way of thinking that is the system that is telling us to do the IPR, otherwise does not work. It's not true. This is just because we clicked on allow IPR and the software is doing the IPR. It's just deciding how to do it. If we don't like it, then we can change it. So this is very important. And that's why I always talk about customized appliance, because I know that this is a big difference. This is a big difference to, let's say, understand and to get used to.
Thank you, Doctor. Okay, next challenge. I have full control with braces, but less control with Invisalign or clear aligners. I think we've kind of covered that already, but maybe if you want to summarize that one.
If we have 10 extra minutes, I will use this case in order to see the control. I don't know if we...
Yeah, we have time, absolutely.
Okay, so I will then definitely use this case so we can at least see one extra. And in order to talk about control movement, because actually I think that this one is going to be a very good example on how to control the cases and the movements of your cases with Invisalign, okay? Taking advantage not only about, let's say, the aligners itself, the customized appliance, but I think that actually here it's going to be a lot more about also the treatment planning. So this case, look at the profile and look at the smile. Okay, the smile, you see it's there is some crowding and the upper arch is kind of an arrow. These patients came to my practice after almost 1 year of going to different orthodontists, because everyone were saying that she was a surgical treatment. She was a surgical treatment because of this. And actually, if you see this could easily be a surgical treatment. But you know what? Especially in Italy where I live, nobody with that profile will ever ever do surgery. It's impossible. They do surgery if there's a major aesthetic concern about the profile or asymmetry. Otherwise, they will never do that where I live. We're not in Milan, we're not in Rome, okay? So they don't take it as easy. So I decided that actually, obviously this is a very challenging case because it's open bite, okay? Has a class 3 on the left, more severe for the canine, less severe for the molar, but it's for sure a class 3. The mandible is deviated to the right. Anterior crossbite, 1.1 is in crossbite. We have a posterior crossbite, so the open bite, we see that. Posterior crossbite, you see 1.6, it's fully in crossbite. On the other side, it's a little bit less, okay? Only, let's say the premolars are in crossbite, and the upper arch is definitely narrow. Now, why it is challenging and why I think that it's perfect to answer Peter's questions is because of the control movements. Here is going to be a key factor, and I honestly think that dealing these malocclusions without surgery with fixed braces will definitely need mini screws somewhere, because you know, whatever you want to do, I mean, just solving the occlusion, if you start thinking about distalization of the lower molars, I mean, you're going to open the bite like crazy. Correcting that crossbite, you're going to open the bite a lot. And here, actually, we cannot open the bite, but actually we want to close the bite. So here the vertical control is going to be a key factor in order to, if we really want to solve all the issues. Otherwise, we may plan a compromise. OPG and SEF. So OPG, see the 3.8 is still there. Now, to make this quick, okay, I don't want to start a discussion about what kind of treatment plan I decided to do, but actually I saw, thanks to the clean check and to a digital setup, that I could solve everything. So I went here looking at the OPG and I said, okay, I can do a molar distalization because I can extract 3.8. Extracting 3.8 1 week before starting the treatment gives me, you know, the regional acceleration phenomenon. Remember, the biology is the same. I can distalize. I know I'm going to have a good vertical control because of the aligners, and I can solve the class 3 here. But then I have an anterior crossbite. And what about this? So I decided that I could sacrifice 3.2 because of the anterior crossbite. And on the other side, it was easier. Cross elastics, overcorrection of the expansion, and triangle elastics to kind of helping in case the vertical control. This was my biomechanical plan in order to solve this malocclusion. And this is how it looks on the clean check. You know what I'm doing? I'm doing incisor extraction. I'm planning a class 1 on the right and a class 1 on the left. I should have a huge amount of overjet. Instead, here, I can see that there's a bolt-on discrepancy because of the upper laterals, and that doing some extra IPR on the upper, I can compensate that, and actually I can have a very nice overjet, even if I'm extracting, look at this, 1 incisor. And you see there's no vertical bite jump. Here it's only vertical control. This is everything passive. The only thing that I've done for the last few months, I've used triangle elastics on the right side. So you see, planning something like this with fix, it would be very, very difficult. So the control that you can have, looking at also the numbers, 2.3 has 3.6 millimeters of extrusion. 1.3 is a little bit less than 3. Lower distalization was 1.9 and 2 for the 7. So these are quite severe movements. But if you look here, most of them were done with, you see, conventional attachment, optimized attachment. So here it's more than 3 millimeters. This is how better the new optimized attachments are to deal with these movements. Obviously, I told you I extracted that. And look at the sequence. Class 3 elastics, look how the spaces are there. Cross elastics on the other side, 8 months, 26 aligners. Here, I decided that on the right side, I wanted to get some, let me say, boost from the triangle elastics in order to close that bite, okay? And this is the final result after 12 months. Let's stop a second. 12 months, 41 aligners. Look at the canine on the left. It's perfect? No. Is this a good result yet? Absolutely yes. And here, I think, could be another example also for the additional aligners. Would you be worried to do 8, 10 aligners of refinement after 12 months of treatment of a case like this? I don't think so. That's my finishing. You see, I take my OPG before the refinement, as you do before the finishing. I had some spaces. I still had the attachments, and I decided what to do. But look at also the molars. That's a very good result. I thought I would have more distal tipping. Instead, they don't look so much distally tipped. This is what I achieved, obviously with a lot of overexpansion, but here I wanted to show you also the refinement. 9 aligners. I changed only the attachments on the centrals, on the incisors, because of aesthetic reason. I didn't change one extra attachment. They were in good shape. I just focused more on closing, improving the settling and closing the space distal to 3.1, that one, you see? This is a refinement. This is a finishing. How easy it is. You focus only on the movements you want. You see the molars are not even moving, are blocked. So that's how you do that. Here I blocked also the 5. Very precise. You finish your treatment, and this is the final result. 15 months of treatment. 15 months of treatment. So the pre and post gives you, I think, a good idea of how many things you can do together, controlling also the movements. And in this case, the main concern was the vertical. Okay, the molar distalization with class 3 elastics, the overcorrection and cross elastics for the cross. You close the bite with extrusion and taking advantage of the aligners, vertical control. And the only extra help for the vertical was 1 monolateral triangle elastics for the last 3 months of treatment. And all this, look at the stuff before and after. This is, I think, what could be called a controlled treatment and movements. The smile, and this is the follow-up after 1 year. Even here, I will see Margherita next week, and this is gonna be 2 years after the end of the treatment. But if after 1 year, you see here the settling, it's actually better. Here it's not the same, okay? There was minor changes, but I have to say that everything is stable and in good shape. So I hope this was an example for both the additional aligners, how I see the additional aligners, and how you should use additional aligners with this system, and especially for the follow-up. Okay, not for the follow-up, for the control of the movements.
Fantastic, Doctor. I actually haven't seen ortho cases in quite a while now. I'm kind of behind the scenes a little bit more, but so it's amazing to see some of the results come through, especially with the newer innovations. So yeah, I mean, all I can say is hats off. One of the other concerns, which I think you've answered throughout the presentation, is that doctors can only treat simple cases with Invisalign, and that it can only be used on very selective cases because it's not a full solution. But I think for the purpose of this discussion, I think we have demonstrated the capabilities of the product that we're actually working with, and Invisalign is as a full orthodontic system. I would love to hear from some of the orthodontists who are online and who are maybe very curious after your presentation. I'd love to get some additional questions. No question is a silly question. Please, now is your time to ask the questions. Challenge us. Challenge Dr. Federico. Please, now is your time. Are there any questions? Please type into the group if there are.
Any question, any kind of topic, okay? I mean, it's, I was thinking to go also over just a few examples with teenagers, but I know it's already quite late. So, but if you have any questions about it, about the compliance, I mean, any questions is going to be very welcome.
So, Doctor, can I ask you then, as we allow the doctors to take their time to type up a question, could you please give your opinion around compliance? Because that is actually, believe it or not, one of the questions that didn't come from the doctors in South Africa, but I'm sure some of the orthodontists on the line actually have that concern, is around the fact that Invisalign is a removable appliance and compliance can be an issue. Can you elaborate and give us your input on that?
Absolutely, yes. And yeah, you're right. It's one of the questions that I have to probably answer more often. And not only to doctors, okay, but also to parents, because I really, what I think, started treating all my cases with Invisalign when I decided that it was time that, okay, I'm seeing good results. It's time to go all in with teenagers, because I'm seeing, I mean, the handling, you know, the oral hygiene is so bad. It's so easier. Doing distalization is so much easier and faster than what I was used to do with, you know, pendulum, distal jet, and etc. So I saw so many benefits that I decided to go all in. It was part of, it took some time to understand the psychology behind using a removable appliance and all the fears of parents, because let me tell you, teenagers are gonna love it. Okay, they still now, not that often, because they usually come to my practice because they saw a friend, a cousin, a teammate that is wearing aligners, and they want to wear aligners and not fixed braces. So let's say that nowadays I have new visits of people coming for that. But at the beginning was, okay, they come to the orthodontist and I say, okay, we may use Invisalign, but that's removable. No, forget about it. I mean, my son is never going to use it. So how to deal with compliance? I had one slide. I'm just going to show this. That gives my point of view on the compliance. This is taken from Anthony Gennari. And in this article of one phase versus two phases, he said that an efficient treatment, our goal is an efficient treatment in the shortest time possible with less energy waste and highest patient satisfaction. It's a pretty big goal, but that's the summary of how you have successful treatment with any kind of teenagers, especially class 2 or whatever treatment you want to do. But you have to work on the psychology. You have to use all the tools. For example, I always show the clean check, especially now with the in-face visualization, to teenagers more than adults, because for them, remember, they're digitally born, where you have to talk the same language. If you start talking about difficult words to their parents, they're just playing with their cell phones. You're not engaging anything. We're not engaged with the patient. Instead, they sit on the chair. On the big screen, I project the clean check. and they start seeing their smile changing, you know them taking pictures or making a video. Doctor, can I take a video? Sure, take a video, because I want to show that to my friends. They feel engaged. And it's not only the good stuff, it's where I tell them exactly how long is going to be the treatment, what kind of elastics they're going to use, for how long, starting by night, then 16 hours per day, and sometimes also at school. But you see, I always try to make deals with them, because in this way I found that, also studying the psychology of teenagers, they have to accept that what you're saying is reasonable. Not true, not okay, but reasonable. If it's reasonable, they're gonna start following what you said. And if you really can build a trust with them, so if actually they're saying that actually you are doing what you said at the beginning, they're gonna continue, because they understand that if they continue following your advices, they're gonna finish in 13 months, in 15 months. So this is the approach I have with them, and actually this is paying back a lot. I stopped asking for 10 in order to obtain 6 with teenagers. I don't know, it's probably me, but it doesn't work for me. It's like, if you ask for 10, probably it's here in Italy, but if you ask for 10 and for teenagers' mind it's not reasonable, you're done. They're not going to wear the elastics, they're going to tell you things that they don't do, and you're going to start fighting with them. So keep them engaged, use the technology, use the communications that they are used to have on a daily basis. And with the parents, what I always tell them is that the no compliance treatment does not exist, because if there are no compliance on taking care of the appliance, of the fixed appliance, if they start breaking the appliance every 2 months, if their oral hygiene is very bad, you're going to have a lot of problems. So I started feeling that fighting against your patients with something fixed because it's not compliance never gave me the results that I expected. Because at the end, without the compliance of your patients, it's never going to be possible to have good results. So it's just a different compliance. It's going to be more comfortable, no problems with oral hygiene, but of course, it's going to be more aesthetic, but they have to take care a little bit more on taking on and off their aligners, sometimes wearing elastics, but that's not a big deal, okay? They have to take care of the appliance. Elastics does not make any difference for them. So this is, let's say, in few words, okay, we may talk about compliance in class 2 for one day, if I'm sure we will have the chance. But for now, I think that's what I do differently from the past, and that's what I've learned with my experience with teenagers and Invisalign.
Thank you so much, Doctor. It's a perfect insight and summary. Before there's anything else clinically, I think it's very important to put certain things into context that we've talked about tonight. Dr. Federico, up on the screen right now, you have patient satisfaction. Well, to the orthodontists on the call tonight, what if I told you that we have an orthodontic solution that can improve your patient's experience, drive practice efficacy, drive practice efficiency, drive treatment efficacy, and help you to grow your orthodontic clinic? Is that not a solution that you would jump at the opportunity to be a part of? Because the reason I ask that question is that is the solution that we have on the table here. We are absolutely gunning to work with people who are willing to work with us. And for some of you on the lines tonight, this computerized orthodontics must be maybe a little bit crazy and a little bit out there for you. But I can guarantee you one thing. One thing that we do well is the follow-up support. And I hope that certain orthodontists on the line here will be able to back us up on that. We are absolutely committed, from both Align Technology as well as Wright Milners, we're absolutely committed in holding your hand and making sure that we walk that journey with you. So you don't necessarily need to drop off this call tonight and feel afraid. We are here to help you transition your business or your orthodontic clinic from a more, maybe a slightly analog way of working to a more digitized way of working. And another thing I want you to ask yourselves, please think about what either the present or the very near future looks like when it comes to the orthodontic industry. Will you be treating patients in an analog way? Will you be taking silicone impressions? Will you be treating with metal brackets and wires in the near future? Because I can guarantee you the answer is no. Now, whether or not you wish to challenge me on that, I would more than happy to have that discussion with you. But working in the industry over the last 7 years has taught me one thing, is that we are on the crest of a wave when it comes to digitization of orthodontics, and digital always wins. You see it in every single industry. There are very basic examples where you have, for example, the Kodak Instant, what's it called? The Kodak Instant camera, where you used to wind up the picture, we used to wind up the instant camera, and now Kodak are basically out of business, right? They didn't necessarily move with the times. That's just one example. Nokia is another example. We are on the crest of that wave. We are already in more, let's say, developed markets such as Europe. Dr. Federico will know this. But I can tell you here right now, there is a huge opportunity for doctors who are willing to work and put in the time and effort in order to digitize their practices. We're here to help you every step of the way, and it's an incredibly exciting journey. Another thing, Doctor, you talked about is the size of the business. I think that's a really nice thing to talk about. But sometimes it can be thought of, that we are just this big company. Well, again, we are a big company because we have invested so much money in research and development to make our product better for you, the orthodontist, and for your patients. And another thing, we are continuously innovating to make that product and that experience even better for you. I think that's our desire. Our desire is to deliver excellence every step of the way. And we might be a big company, but with our partner on the ground, Bright Milliners, and with my very close support, I can guarantee you that we will make this journey as personalized as you want it. Okay, so I just wanted to make sure that the doctors on the line don't necessarily kind of finish this and think, wow, what next? Well, I can tell you that we are all here to help you on this journey, no matter what stage you are at, whether you're at the beginning, middle, or advanced. We're here to help you. So we've got your back, Dr. Federico. I think this has been a really fantastic session so far this evening. I'm going to come back to one or two questions that have come in. And then we can look to slowly wrap up the session. Is there anything else you wish to add, Doctor?
Yeah, just to take your words about the future of our profession. This is usually my last slides, and if you want to see, it's a very nice reading, and it's about the new era of healthcare, and that is called precision medicine. And this reading, in fact, the title, you see, it's Everybody is Unique. So what you said is exactly what I believe. I mean, here we finally have, it's not only that it's digital, that is absolutely not the future, it's the present, but that finally we have a fully customized appliance with a digital treatment planning. So maybe I always say, yeah, maybe we're going to have an evolution of the aligner itself. Maybe the appliance is going to be something more efficient, a different material. Absolutely. I mean, I hope that that's going to be the future. But the treatment planning, the customized appliance, I mean, the clean check, the software part, and dealing with something that it's different for every single patient is not going to change. This is going to be our, basic treatment for every single one. Okay. So what you are, I know it takes, okay, with this system, obviously you're going out of your comfort zone, okay? Dealing with the clean check, we know it's not that easy, and that's what Peter said about, you know, the support that Align always give to his doctors. This is very important. This is a big plus, I believe, that nobody else have. And once you are into, you have done your change, the change in your mindset, you're going to see that everything will become clearer. You're going to see the benefits. You're going to see the advantages. You're going to see how to do all this, some of these things that I showed you. But the most important thing is that you're not doing this because you want to use the aligners right now. That's obviously also the reason, but because this is how our profession is going to be in the future. And let's say that the system, the Invisalign system, is already done, okay, and ready to be used in this way.
Thank you so much, Dr. Federico. Okay, one final question, well, so far from Dr. Hugo, is some operators say that because of their wedge shape and cross-section, lateral incisors tend to intrude unless attachments are used. Do you have a comment about that?
Okay, now with the new protocols and actually with the G7, it was a few years ago, in order to, let's say, take care of that problem, you see that often we have attachments. I don't want to say that if you don't use attachment, you're going to have the intrusion. Actually, it depends on what the other two big teeth next to the laterals are doing. So the problem of the lateral is not only that it's a small tooth and that the shape is not ideal to have a good tracking, but actually is that it next to two big teeth that are the centrals and the canines. So it's not always like that. Actually, now with the new protocols, again, it happens less and less. But for example, on the opposite, if you need to extrude, you have to be sure to have the attachment, a proper attachment, sometimes create some extra space in order to reduce the friction. So we have to take an extra care of the laterals, but I cannot say you always have to add an attachment, because that's not what I do. I mean, it's not necessary that often. But an extra care, yes.
Thank you, doctor. If there are any other questions from the group, please add it into the questions or comments box, please. If not, we'll wait a minute. I have a comment to make to the doctors of South Africa. We have put a phenomenal amount of work into making sure that, first of all, you have the right partner on the ground to help you. Second of all, that we are absolutely committed to working with you moving forward. Third, you've challenged us. You've expressed your concerns, your frustrations about Invisalign in the past and your past experiences. We're absolutely committed to changing that. In the past, you may have dealt with a product that was inferior or less complete than it is now, or you may have dealt with inefficient or inferior support. But I can guarantee you that the support that you are going to receive moving forward will enable you to digitize your clinic, to help you develop a more profitable orthodontic clinic that has a better patient experience, which will help you to treat more patients with a more seamless way of how you work together with your staff. I can promise you that this is an absolute game changer for anybody on this line who sees themselves and their clinic as staying relevant in the future, okay? I cannot express this enough, but if you are serious about the future of your orthodontic clinic, then it's a good job that you are on this call tonight. So you've challenged us. My challenge to you now is to take the learnings and the opportunity that you've had on this call tonight. Let's take it to the next level. Let's have those personalized discussions with myself, with Mark, with Chantel and Nikita from the Wright Milners team to help you understand what are the next steps on your Invisalign journey. Okay? And I know that Dr. Federico is an absolutely instrumental part of our progress and our development in South Africa this year. And I want to take this time out to sincerely thank him for his presentation tonight. I think he put a lot of work into it, and it's clear to see that he's very passionate about what he does. And I sincerely appreciate it, Dr. Federico. Thank you so much.
Thank you so much, Peter. Thanks so much, Peter. It's my pleasure being here with you tonight. And I want to thank all the doctors for also sharing your experience and feedbacks, and with this, let's say, beautiful sunset on the Table Mountains. And I hope we managed to, let's say, cover and some of the doubts that came out from your past experience with the liners. As Peter said, I mean, the software, the system is evolving so fast. This is something that also, as a speaker, sometimes shock us. Okay, we just see the innovation sometimes because they're minor innovations, but they're already there on the clean check, and they just use like the big announcement only for really new things. So something that we could expect every 6 months in the past now is on monthly basis. So we're all very excited, and I'm glad you can feel the passion that I have on this system, because really in the last 5 years it's been a revolution for also us that we teach this, and we also benefit, obviously, and also our patients benefit from the advantages, the new features. And I just heard that, okay, this year you're going to have the MA, the new IT rules, so it's going to be very, very exciting year ahead.
Absolutely. Thank you so much, Doctor. So to the orthodontists on the call, the ball is in your court. We're here ready to help you on your journey. So Chantel will be in touch with you to give you an update. We have a course for orthodontics coming up, which will be run by Dr. Federico. The course is on the 6th of June. We run a 3-course module. The first module will be on the 8th of May. We also have a module coming up actually this weekend also, which is an introductory module followed by the certification with Dr. Federico. So if you want more information and are interested in taking the next step on your I suppose digital journey, then let's get speaking. Let's have those conversations, and let's take those steps together. So a sincere thanks to everybody. I am super excited about the future of Invisalign and iTero in South Africa. Thank you to Chantel, to Mark, Nikita from Wright Milners. Thanks to Dr. Federico once again, and most importantly to everybody who stayed online late into the evening. It's 10:04 here at night. I need to go to sleep. Thank you from the bottom of my heart, and I hope to work with you in the very near future. So with that, we can close the call.
Thank you all, and thanks for being here. Thank you, Shmi, Mark, and hopefully we'll see you again soon on the next continuing education events for South Africa and Invisalign, and hopefully soon also live. That's my obviously biggest desire.
Thank you so much, Doctor. Thank you for everybody.
Thank you, Dr. Migliori. Thank you, Peter. Bye-bye, everyone. Thank you for joining.
Bye-bye. Take care.
Thank you, everybody. Bye. Bye.
Bye.